Well, here we are, talking cardiology in 12 leads again. We're going to cover Chapter 5, and it's very short. It's things that you've already learned. It's just combining patients that have more than one block. So these are patients that are at risk for a complete heart block, which is a bad thing. So what we're going to talk about very briefly is defining the three types of bifascicular blocks, describe the clinical implications of a patient that would have these bifascicular blocks. We're going to list some examples or talk about some examples of those that are at high risk for these blocks. Then we're going to identify steps that we can take to take care of these patients. And then we're going to practice a little bit of 12-lead interpretation on these particular blocks. So this really isn't going to take very long, and I think you're going to find it's much easier than you thought. Okay, so this is what a bifascicular block would look like on a 12-lead ECG. There's a couple things here that I think you're going to recognize. Knowing what you know from the past two chapters, I think you could recognize a block by looking at leads 1, 2, and 3. And remember again, leads 1, 2, and 3 is looking at axis deviation, and from that we can determine some blocks. So in leads 1, 2, and 3, we have lead 1 is upright, leads 2 and 3 are down, and right up here we have an axis deviation of 83 degrees, negative 83 degrees. So looking at your handy dandy little box that we had last week, if you have that handy, it'll come in nicely for this one. If you look at that little box, you're going to find that we do have a block here, and that block is going to cause us some problems. So if we have an upright and then down and down, we know that this is an anterior hemiblock. And so then looking at the axis deviation, we have a negative 83 and a negative 40 to a negative 90 fits in that anterior hemiblock category. So we have an anterior hemiblock, and then we have a wide QRS here. And if we can see there, let me see if I can get this. I don't think I can get it any bigger. But if you look, there is a notch in it right there that you can see. And a couple of these others, there's a little notch maybe right in there. Kind of hard to see. There's a notch right in here where it comes up and then switches over. And if this were bigger, you could certainly see it better. But we do have that wide QRS on half of the QRS is wide. So looking at that, we would find our J point in V1, which would be right here, come over, make our triangle, and this is an upward deflection. And an upward deflection, remember with your turn signal, if you're going to turn your signal up, then you're going to have a right bundle branch block. So this patient has two blocks, okay? One of them we recognize him from the axis deviation, and the other the bundle branch block. So because of that, we're calling this a bifascicular block, meaning there's two fascicles that are blocked. Okay? Now because of this, the fact that these patients are at great risk for a complete heart block and cardiac arrest, we're going to move pretty quickly. We call these severe degrees of block. And those blocks, when bundled together, can be quite detrimental. So the blocks that we're considering when we're talking about two or more blocks are second degree type 2, a third degree, a complete heart block, a bifascicular block, which is what we have here, a first degree block, plus a hemiblock, a first degree block plus a bundle branch block, or any time you say or imply a block twice in the interpretation, the patient's at high risk for complete heart block. Here's the deal with these guys. Okay. Antiarrhythmics, for the most part, are contraindicated. Okay. Lidocaine, which is our cheaper antidysrhythmic or antiarrhythmic. It has a cousin, which we used to give pretty regularly. It is still in the ACLS algorithms. It's probably down farther than you talked about in your ACLS class, so we will discuss it a little further, but it's called procainamide. It's a cousin to lidocaine. You can see the cane in there. And then amiodarone. So amiodarone is contraindicated if there's a second or third degree block. So lidocaine and procainamide are also contraindicated. Morphine should be given with caution in these blocks. So you've got a patient with pain. Morphine can lower blood pressure. So we want to make sure we know what their blood pressure is going to be, and then use it very gently. You wouldn't want to start out with a big dose because they're in a lot of pain. Start low and see how it's going to react. Okay. So we're looking for blocks of 2 of the 3 pathways that contract the ventricles in an organized fashion. So, to care for these patients, okay, we're going to put the A-Fib pads on them. Number 1, these guys warrant putting the big pads on. Okay. We're going to be prepared to start CPR and to start resuscitation on these. We're also going to be prepared for low blood pressure or hemodynamic compromise. So hypoxia, low blood pressures, and we could have QRSs wider than 0.17 seconds or 170 milliseconds, which is going to be more than 5 boxes. So these are very wide QRSs, which means your ventricles are contracting very slowly, which means that you're going to have a diminished cardiac output and definitely a lower blood pressure. So if we look at this one, it says on the bottom here, it's kind of a giving, we have an anterior heart block. Okay, we're going to know that, and I think this is the same one we just looked at. It is. That we have that upward deflection in lead 1, down in lead 2, down in lead 3, and then the negative 83 axis deviation. So we know because of those factors we have an anterior heart block there. And then looking over here, we've got a wide QRS, especially in AVR and lead 2, it's wide. So we're going to pop up here to lead V1 and take a look at that. We've got our little notching right there in AVR. So we're going to take a look at this, and we're going to recognize that that is, because it's deflected upward, a right heart block. Or I mean a right bundle branch block, I'm sorry. Okay. So this one is the posterior heart block. So we're going to look at leads 1, 2, and 3. Okay. Lead 1 is down. Lead 2 is up. And lead 3 is up. So in looking at our handy dandy little chart that we have and love so well, you know what, looking at lead 1, it is down. Yes, down is what I said. Lead 1 is down. Lead 2 is up, so in this one doesn't really matter. And lead 3 is up. And then looking at our axis deviation, it's 140. So between 90 and 180 is our posterior hemiblock range. This fits that posterior hemiblock perfectly. But we've got some wide QRS as you look in lead V2 and V1. We see this rabbit ear notch. And let's see if we can see it anyplace else. We can see it down here in V3. We can kind of see it a little here in AVL where it's notched. Right up here it's notched. We can see it in V4, that notching on the top. We can see it in V5. So we're going to look at V1. And I'm telling you, it's crazy. So we got to find the J point. It goes up, down. I'm thinking down in here, kind of. This one's difficult. Okay, probably right in there is our J point. So this one's going to go upward. So we've got our J point right there and go up. That's going to be a right bundle branch block. Okay. So there are some more here for you to work through. You can see this one is a left bundle branch block. But let's look at our look at the rabbit ears on lead 1. That would be an indicator that we've got a bundle branch block. Okay. Oops, I'm sorry. So let's look. We've got up, up, and down. So up, and down is looks like up, and down could be a physiologically left axis. Okay. And if we look, we've got an axis deviation of 19. That fits right in there. So that's a physiological left axis. It is not a block. Okay. But let's look over here. These are kind of crazy looking QRSs in V1. So we'll find our J point, which is there. It's going to be down. So this will be a left bundle branch block. Okay. And that's all it is. Okay. So I'm going to put this PowerPoint up for you to look through. Basically, there's nothing new to look for here. You know how to do all this. You're just looking to see if you can find a combination of 2 blocks at one time. So the other thing that we're going to be looking for is, take a quick look in lead V2 and see if you see a heart block. It's hard to tell on these guys because you don't have enough of a strip to know if you've got a first degree, second degree, type 1, type 2, or third degree block there. But if you have the continuous running strip on the bottom, sometimes it's easier to tell. Okay. So take a look at these and see what you can find. You're seeing some real obvious rabbit ears here that make it easy. But this is a first degree, okay, plus a hemiblock. And you can see the first degree here. It starts here, and our QS doesn't start here. So it's barely a first degree. But if you look over here in 1, 2, and 3, you've got upright, down, and down. So if it's up, down, and down, we're looking at an anterior hemiblock, and then you look at the axis deviation is -46, which fits right in there. So we've got a first degree block, just barely, and a hemiblock. So this patient, although the first degree is what you're seeing, with that hemiblock, that makes it pretty significant. Okay. So take a look at these, see if you can see if these are bifascicular and what you can see in them, and then bring your questions to class when you come on, what day are we together? Wednesday. All right. I hope you have an awesome rest of your week. Talk to you soon. Okay. Well, we've got your attention. I'm going to go ahead and go through Chapter 6 real quick, the wide complex tachycardia. And I know this seems a little bit complicated, but they're just kind of trying to give you all of the criteria for VTach. Some of it is going to be doable in the field, some of it not so much. So we'll talk about wide complex tachycardia. I think you guys have been through ACLS enough to know what we might do for this, but we're going to talk about how this is going to look in a 12 lead because you're only seeing small segments. So we'll talk about the pitfalls of diagnosing a wide complex tachycardia, describing the complications resulting from it. We're going to look at 4 different very simple criteria for differentiating VTach from SVT, and then we're going to identify both of those on a series of 12 lead practice strips for you. Okay. So oftentimes we look at lead 2 and we go with that. But history tells us, and so does science, that about 34% of the time we're right if we look at only lead 2. So we do need to look at something a little more than that when diagnosing a wide complex tachycardia. The other thing we need to think about is do not rely on the machine's interpretation of these rhythms. They are notoriously wrong. Another pitfall are vital signs and patient presentation. If our patient is in a wide complex tachycardia, we would expect them to present with some hemodynamic insignificance, or at least not stay stable very long. So that's a clinical sign that we can look at. You know, we always talk about the strips and the 12 lead and reading all that, but truthfully, we have got to treat our patient and not the machine. So above everything, treat your patient. If he doesn't appear sick, look sick, don't get your panties in a wad over this yet. We also need to think about atrial fibrillation and how that can present sometimes and look similar to a wide complex tachycardia. And then we need to look at SVT. When is it more common? So here is some machine logic. I think you can probably look at this and recognize what rhythm it is. But the interpretation from the machine says it's atrial tachycardia with a second degree AV block, a Mobitz type 2, nonspecific interventricular conduction block, a right ventricular hypertrophy, you guys know I love that word, inferior infarct, probably a recent anterior lateral infarct, and probably a recent abnormal EKG. Duh. I think it definitely missed the boat on this. So we can't go with that. We're going to have to go with our own brain on these. Okay, so things that we're looking for. Is the QRS wider than 12 or 0.12 seconds or 120 milliseconds? That's goes right back to our very basic EKG rules. QRS should be less than 0.12 seconds. So we have to look at that. We look at the axis criteria, that axis deviation, because that can be helpful. We're going to look at the morphology or how the waves are shaped in leads V1 and V6. Those are big key indicator leads. So V1 we also use for right bundle branch or for bundle branch blocks. But V1 and V6 we're going to look at in these wide complex. And then we're going to look for concordance, which means they're all the same. So in our chest leads, our V leads, are all of them up or are all of them down? Because that'll be some clinical significance. And then we're going to look at our atrial ventricular association. So are our atrium and our ventricles talking to each other, or are they not? And if they're not, then we might look at a wide complex tachycardia. And then obviously we want to talk to our patient and get their history and get their medications and find out what's going on with them. So our very first criteria for looking for V-tach is looking at leads 1, 2, and 3, which again measures our axis deviation. So we're going to look at leads 1, 2, and 3. If they're all down, that tells us we have extreme right axis deviation. And then we're also going to look at our V1. Okay? If our V1 is up, 1, 2, and 3 are down, V1 is up, it's V-tach. Okay? So that's kind of really at a quick glance, if you're not sure what you got, those are your go-to leads. 1, 2, and 3, so you're checking axis deviation and your MCL1 or V1. Okay. So let's look at what our machine tells us. Okay, it tells us this is an undetermined rhythm. So it's an abnormal right axis deviation. So we're looking at leads 1, 2, and 3. They are all down. The next thing it says is a right bundle branch block. So if you look at V1, it is upright, which is indicative of a right bundle branch block. And you can see there's a little notch there. So you can see why it's reading right bundle branch block. Okay, it cannot rule out an anterior infarct. So it's looking at J points, and we're looking for ST elevation. And since they're kind of all over, it's having a hard time finding it. It can't rule out an interior infarct, and there's marked ST depression, possible subendocardial injury, acute MI suspected. I would say maybe it's right, okay? So they threw a lot of stuff in there. It's just throwing all the stuff out there that it's picking up, but it's not able to put that into a particular rhythm. We could quickly look at that, look at 1, 2, and 3. They're both down. Look at look at V1, it's up. We have V-tach. And just looking at the rhythm, you can kind of see that. Okay. Here's another criteria. If we have, instead of extreme right axis, if we have right axis deviation, so lead 1 is down, 2 and 3 is up, but our MCL is down, or our V1 is down. So it's down, up, up, down. That's 90% specific for V-tach. Okay. And that presents this way. You can look at 1, 2, and 3. You've got down, up, up, and then you look at V1, and that is down, which is it. And this gets really difficult because it's like, what's up and what's down? Where's the top and where's the bottom? So, but you can see you probably have a coming up into your STQRS down. Here's your J point. So we're going to call this up. Okay. And you're going to see here it's calling it a right bundle branch block, left posterior fascicular block. And there's probably definitely some blocks there, but okay, so morphology is the shape. So sometimes we get the shape, and these sometimes are just like really easy to see. Boom, they're right there. So we're going to look at lead 1, okay, or I mean not lead 1, V1, the same one we're looking at for everything else, and we're going to look at the morphology of that. If you see them shaped like any of these 3, like in A, it's a taller left peak than a right peak. I think it kind of looks like a crooked cowboy hat, but that's a positive sign. Okay, a single upright peak, as in B, is a positive sign. Or C is what we call a fireman's hat, where it's kind of sloped, looks like it's taller in the front than the back. Those are all diagnostic of ventricular tachycardia. Okay. If you look in V1 and it has a negative deflection, we can see those this way. A fat R wave, so it's got that Q R before it starts going down down to the S wave. And then you can see in B and C there's a notch or a slur in that initial downstroke. And those are indicative of VTach as well. Okay. So looking in lead 6, we talked about what V1 is going to look like. V6 can either be down, okay, or in the middle one there, it's a predominantly negative deflection. So remember, we look at how many boxes it goes up and how many it goes down. The greater one is what we're going to count that for. So the first one is all down. The middle one is more down than up. And then the last one shows an initial downward deflection and then it goes up. So all of those could be VTach in looking at V6. So basically, if V6 goes up, then it doesn't fit the criteria. But here where it's got those downward deflections, it fits. Okay, so we're going to look over here at V6. You can see it is primarily down. So V6, but we look at, let's look at 1, 2, and 3. 1 is down, 2 is down, 3 is up, and V1 is up, and V6 is down. Okay. Okay, so if our chest leads are all up or all down, okay, then we need to look at this. If they're all up, it could be VTach, but we need to ask about a history of what we call Wolff-Parkinson's White. And Wolff-Parkinson's White is a cardiology defect, I guess, so to speak. It's got an extra electrical pathway in it, and it can sometimes very easily send a patient into tachycardia. So if you've got Wolff-Parkinson's White, it may be that extra pathway that we're seeing here and not actually VTach. So if you've got that history, look at our patient. If they're all down, then very easily could be VTach, but we need to look and make sure we don't have a left bundle branch block. So we're going to look at V1 for that. Okay. So there's our all down. Okay. With Wolff-Parkinson's White, we're going to look in V3 to V6, lead 1, and AVL. And what you're going to see here mostly is what we call delta waves, or those slurred. And you can see as it starts to go up here, instead of going up drastically or nice sharp, it's kind of arched. And we call that a slur. So when we have that slurred R wave, that's indicative of Wolff-Parkinson's White. So that's what we're looking for with that. Okay. Now this is a very accurate way. It's not, you have to almost have a calibrator or calipers in the field with you to be able to actually measure this out. But if you've got time or you're in an ER setting, you can. So we're going to measure from the start of the R wave. It's got it right here. And then we're going to measure over and down to the what we call the nadir point of the S wave, or the peak of the S wave. And if that measures greater than 100 milliseconds, then we have VTach. Okay, this is a very accurate way, but again, you've got to do that calculation and calibration to make sure that you know what you're doing. Okay, so let's look at this. This one is not regular. So when we go back to our basics, we're saying, and this is in lead 1. So we're looking at a wide complex for sure, but it's not regular. And we can see that when we look at the peaks, it's kind of got crazy intervals. Okay, so irregular rhythms generally tell us it's A-Fib or V-Fib. Those are the two irregular rhythms unless we have a heart block. So we need to make sure it's not A-Fib, because sometimes when we talked about this, when we talked about bundle branch blocks, you get wide complexes that's called rate-dependent bundle branch block. So if you get A-Fib that's going really fast, you can get that bundle branch block, which will widen your QRSs. And you can kind of see the notches here that would make you think about that. Although with A-Fib, you have crazy chaos where the P wave should be, but our QRSs should still be nice and smooth. And we have some notching here. So you might look at that and look in V1 and see if that is a bundle branch block. Okay. Now, if we can capture a fusion beat, so when we're looking here, we're running a typical 3-lead, 1, 2, and 3. And we see that sixth complex there with the red arrow is what we call an escape beat or a fusion beat. It's kind of just everything kind of catching up, or it's beating so fast that it doesn't have time to reset, and that sixth beat just kind of doesn't really happen very good. If you see that, that is pretty diagnostic of VTach, and it tells you that there's not a lot of association between the atrials and ventricles. Those escape beats happen because they're not talking to one another. So when you get to your patient history, okay, some things we need to say is, have you had a heart attack before? Okay. And a lot of patients have trouble with ventricular rhythms after they've had a heart attack, and there's a little bit of damage to their heart. So that's a really good question to ask when you see a ventricular beat like this or a wide. So have you had a heart attack before? And the second one, did you have fast heart rates after your MI? If they tell you yes to both of those, science tells us 86% chance that what we're seeing this time with the patient presenting wide complex is VTach. So those are two very important questions to ask. Okay, so we're going to start at the top of the criteria, and we're going to list everything that's positive for VTach. Okay, so we're going to look at that extreme right axis deviation and positive V1. Okay. We are going to look at our morphology of our QRS, or the shape of our QRS in V1. Okay. Then we're going to look at the shape of our QRS in V6. And then we're going to look if we've got extreme right axis deviation. So we're going to have to measure our axis in all of this. And we're going to look at V1. If it's negative, then that's a finding of VTach. Okay. We're going to look at V1 through V6. Are they all the same? Are they all up or are they all down? Okay. Then we're going to look at our RS interval if we have time to be that detailed. And if it's greater than 100 milliseconds in any V lead, that's VTach. Okay. And then we're going to look at our QRS. If it's greater than 140 milliseconds or 0.14 seconds, if it's up, or greater than 160 if it's down in V1, then that will be VTach. So lots and lots of things to think about there. A couple other things I want to talk about. In the book it mentions the Canon waves, Canon A waves. So if you're sitting there looking at your patient and you are noticing pulsations in the jugular veins, but they're not regular, they're not coinciding with the heart rate or with the monitor. If you just get this random pulsation in the jugular veins, those are called Canon A waves. And basically what happens with the Cannon waves. They're pressure waves. The atrium is contracting when the ventricle isn't open. So the atria contracts and there's no place for this blood to go but right back up through the vena cava and up into the jugular veins. If you see that regularly, we would think maybe it's right-sided heart failure. But if it's irregularly, that would be that the ventricles are kind of doing their own thing. So when the atrium contract, the ventricle's a little off beat with it. They're not talking. We have that disassociation. And so they'll be irregular. So watch for those. If you happen to see it, look and see if it matches the monitor. And if it does, then we probably have right-sided heart failure. If it doesn't, then we want to think about that disassociation. The other thing we're going to look for always when we're looking to diagnose a 12 lead is we're looking for P waves. So if there's P waves there, we want to make sure that they're in all leads. You may see a P wave in one lead, but if you don't see it in any other, then it's not a P wave. So we want to look and make sure that we have them. If we see them out of place or isolated, look in a couple other leads because you want to make sure what you're seeing is really what you're seeing. Okay. I think that's about all we've got. So let's look at a couple of these and see if we can talk about those. Okay. So I'm going to let you look at a few of these, but we'll talk. Let's see. Let's pick one out here to talk about. Let's see here. Let's talk about this guy. Okay, so we're going to look at, first of all, we've got wide complexes. We can see that. So let's measure our axis deviation. So let's look at 1, 2, and 3. 1 is down. Okay. 2 is down. And 3 is up. So looking at our chart, or if we got it from memory, we can see that 1 down and 2 down, and lead 3 is up, is a posterior hemiblock, okay? But we're up in V1, so it's down, down, up, down. So V1 is up. So we've got right axis deviation, okay? And we've got the hemiblock. Then we're going to look at our peaks, and we've got a smaller left than a right in V1, but that's not really conclusive of anything. And then let's look at V6, and we've got negative in V6. So that is going to give us our VTAC. Okay, that is conclusive of VTAC. Okay, so kind of use those rules. Go through here. There's a few that we can, it's interesting to read the machine diagnosis and then try and put your own to that makes some sense. So look at these and see if you can kind of muddle through those. Alrighty, and bring your questions to class. Have an awesome week. Thanks.